Thank you all very much for coming. It's my pleasure to welcome you to our new webinar series, What to Expect, a Guide to Prostate Cancer. My name is David James, and I'm the Head of Patient Projects at Prostate Cancer Research. This webinar series is a collaborative project between ourselves and the pharmaceutical company Ipsen. Today we have the first of our webinars in this series, which is called Get to Know the Basics, all about the prostate and prostate cancer. So we're joined today by two wonderful speakers, Professor Mike Kirby and advanced nurse practitioner Liz Cross. Now I'll let them introduce themselves to you, but we're very excited to have them, and thank you both for coming and joining us today. Now this webinar is, as you may know, the first in our 8-part series. So today we'll be focusing on the prostate and prostate cancer, looking at various signs and symptoms, explaining what prostate cancer is and touching on how it is initially discovered and assessed. Next week, we'll focus a bit more on what happens following a GP referral, including the tests and investigations that lead to a prostate cancer diagnosis. Over the course of this series, we will touch on all the different treatment options that are widely available to help treat or manage prostate cancer, explaining what these are, what the risks and possible side effects of these treatments might be, and hopefully helping to demystify what you might expect if you or a loved one has been diagnosed with prostate cancer. For more information about the other episodes in this series, do visit our website, pcr.org.uk/what-to-expect, where you can find out more about them. Now, before we begin, for the purposes of today's presentation and for simplicity, we've used the term men throughout, but this should be considered to include not only men, but also trans women, non-binary people who are assigned male at birth, and some intersex people as well, as they are all also affected by prostate cancer. So now, without further ado, I'd like to invite our first speaker, Liz Cross, who's going to take it away. So Liz, if you'd like to unmute yourself and turn your video on.
Hi, good evening, everybody. Thank you very much for having me. So I am a GP nurse. I work, I have a common role. You'd see me in most GP practices. You might come and see me if you were worried about any urinary symptoms, or if you wanted any bloods taking, or you might come and see me if there are any treatment injections that you were going through at the time. So, fairly common in most GP practices. Okay, so today what I'm going to do is talk you through a little bit of the anatomy, talk about a little bit about prostate cancer, and enlarged prostates, and then I'm going to hand over to Mike to talk about testing. Okay, next slide, please. So here's our basic anatomy lesson. So what is the prostate? So for today, the prostate's that little blue circle that you can see in the middle of that picture. And as you can see, it sits just below the bladder, and it's right in front of the rectum or the back passage. Okay, and it completely surrounds the tube that drains the urine from the bladder. And I think it's really important that you know a little bit about the anatomy so that you understand why we get particular symptoms with enlarged prostates and prostate cancer. So that's why we're going through that today. So what does the prostate do? So the prostate produces the fluid that forms part of the semen, and it also constricts around the urethra when you ejaculate to allow semen rather than urine to pass through. Okay, next slide. Okay, again, here we go. We've got another picture of the prostate. This one goes into a little bit more detail. Again, you can see it sits just below the bladder, and you can see that central urethra that drains the fluid, drains the urine from the bladder. And that goes right the way through the middle of the prostate. And here we can see all the different zones within the prostate. Now, I think it's important to recognize that prostate cancer grows around the outer zones of the prostate. And that's why we tend not to have so many symptoms with early prostate cancer. And we'll go into that a little bit later. And an enlarged prostate, when the prostate gets big, that's why it squeezes on the urethra, that tube that allows urine to drain from the bladder. When that gets squeezed or tightened, That's why we get urinary symptoms, or we get obstructive symptoms, or constrictive symptoms, and that's what's causing us the problem. So whenever the prostate gets enlarged and squeezes on the urethra, then we're going to get symptoms. Okay, so next slide, please. So how big is the prostate? Okay, so the prostate in most young men is about the size of a walnut there, nice little diagram. And then as men grow, it can grow up to the size of about a ping pong ball. And for some men, it can grow even larger, and it will grow up to about the size of a tennis ball. Okay, next slide. Okay, now some of you may have come across this. So this is an enlarged prostate, and we call this condition benign prostatic hyperplasia. Okay, so this is a condition where the prostate cells grow, but this isn't cancer. Prostatic means that it's related to the prostate. Hyperplasia, there's an increased number of cells or organs. Okay, and if you look on the pictures there, particularly the picture on the right hand side, you see the prostate's got quite enlarged, and you can see there's a narrowing on that tube that connects that drains from the bladder. Okay, so this is a really common, particularly for men over the age of 50, and then by about age of 60, about half of men will have some form of BPH, or benign prostate hyperplasia. Okay, and those symptoms include difficulty passing urine, frequent trips to the toilet, particularly at nighttime, urgency or rush to get to the toilet. And then when you get there, you might be stopping and starting. Okay, you may find that you're dribbling when you're going to the toilet. And sometimes it can feel like you've not fully emptied your bladder. So these are the symptoms which are obstructive or constrictive symptoms. Okay, but it can be treated. So often you're more likely to have BPH if you're overweight. So the advice, often lifestyle advice. So making sure that you're exercising regularly. Try and reduce your weight if you can. Try and cut down on sugary, fizzy drinks, caffeinated drinks as well. And particularly if you've got symptoms at nighttime, maybe sometimes restricting your fluids just in the evenings. Okay. And then there are medicines as well. Okay, next slide. So what is prostate cancer? So prostate cancer is malignant cancer. This is when cells in the body grow out of control. Okay, and prostate cancer, as I mentioned in those other slides, tends to grow around the outer zones of the prostate in those glandular cells. Prostate cancer tends to grow a little bit more slowly, and the initial growth is just confined in the prostate. Okay, next slide. But unfortunately, prostate cancer, like other cancers, can grow and can spread. So sometimes the cancer cells can spread outside the body, and they travel through the blood system, and they can spread to other parts of the body. And we call this metastasis. Okay, so this is when cells have grown away from the original cancer, they've spread to other parts of the body, and the cancers can spread. So for prostate cancer, this can go to the bone, liver, and bladder, and unfortunately cause further damage. Okay, next slide, please. So there are ways that we describe cancer, okay? And these staging scales can help us describe what's happening to the cancers there, okay? So stage 1's cancer, so it's early, it's localized, and you might only be able to see this under a microscope, okay? And the tumor is just contained within the prostate. Stage 2, so again, it's early and it's localized, and you can see that on the picture that's in front of you. The tumor's got a little bit bigger, but it's still contained within the prostate. Now, stage 3 cancer, the prostate cancer has got a little bit bigger. It's now grown outside of the capsule of the prostate, and it may start to get big enough that it's starting to press on some of those tubes within the prostate, And then we're going to start seeing symptoms. So we call this locally advanced prostate cancer, stage 3. Okay, stage 4 cancer, unfortunately, the prostate cancer has grown even more. It's grown outside of the prostate and it's started to metastasize. So it's moved to different parts of the body. And again, this is going to be enlarged. It's going to be pressing on that urethra. So we're going to start to get symptoms. Okay. And if the cancer is spread to other parts of the body, for example, bladder, back passage, you're going to get symptoms from that as well. Okay. Next slide, please. Okay, so let's have a little closer look at the prostate. What are some of the signs and symptoms and who gets prostate cancer? Okay, next slide, please. Okay, so if we think back to the anatomy where prostate cancer develops, you often get very few symptoms with those early stages of prostate cancer because it's growing around the outer zones and it's not pressing on that central urethra. Okay. So the prostate cancer needs to get quite big before we start getting any symptoms. So if we look here at this picture, you can see that there's the bladder, there's the prostate and the urethra passing through the prostate. Now this cancer looks like it's got quite big and it's pressing on that central tube that's draining urine from the bladder. So that this poor patient's probably getting some symptoms. Okay, so this is just an illustration. Next slide, please. Okay. So again, we're recapping that in the early stages of prostate cancer, you may not get any symptoms. So stages 1 and 2, early and localized disease, you may not have any symptoms at all. Okay. Stage 3, the cancer is spread a little bit more, might start pressing on that urethra, and you may start getting symptoms. Okay. Stage 4, it's metastasized and the cancer has might have spread out into other parts of the body, other organs. So you might start feeling tired, feeling unwell. You may have bone pain, may start getting some weight loss, and you will have urinary symptoms as well. Okay, because the cancer here is metastasized and spread. Okay, next slide, please. So the tricky thing is that there's a lot of crossover symptoms between benign prostate hyperplasia, BPH, that non-cancerous enlarged prostate, and advanced prostate cancer, when it's the later stages. Okay, so both of these cases, we're going to have difficulty passing urine. You're going to be going to the toilet a lot, particularly at night time. You might be stopping and starting when you do go. You may have a little bit of dribbling, and you might find that it's hard to fully empty your bladder. But there are other signs that this may be cancer and not just an enlarged prostate. For example, you may notice that there's blood in your urine or your semen. You may have pain in your back or your hips. You may have difficulty getting or keeping an erection. You may have some weight loss as well. Okay. And I think now it's time to hand over to Mike.
Thank you very much, Liz. That was very clear and concise. If I could have the next slide, please. Thank you. I'm Professor Mike Kirby. I've had a special interest in prostate cancer. My background is as a GP running the Hertfordshire Primary Care Research Network and working at the hospital doing cardiology and diabetes. And for the last 15 years, I've been working at the Prostate Centre in London. I guess during my career, the thing that's interested me in research topics is my patients. And many years ago, I had a young man in his early 40s come to the surgery with back pain. And it was just at the time when the PSA test had first been developed. It was the late 1980s, in fact. And this man turned out to have very advanced prostate cancer, which had metastasized to his spine, and his PSA was 5,000. And I got thinking, gosh, there must be a better way to diagnose this disease before it gets to this stage. And we decided to do a research project, inviting the men in the practice to come in for a PSA test and a digital rectal examination to see if we could feel any tumor. And in fact, we screened over 700 men and we found 12 tumors. But in the process of doing so, we did some harm by doing biopsies, and some men got infections and ended up in hospital. So when we wrote this up, we said, yes, the PSA test is a test we can use to detect cancer, but by doing so, you do some harm. And one of the things that doctors believe in very strongly is that we should not do any harm. So I guess from Liz's presentation, we need to diagnose men in stage 1 or stage 2, don't we, when we can cure them. And the key to that is knowing, first of all, who is at risk. So certainly black men are more likely to get prostate cancer than white men. 1 in 4 black men will get prostate cancer at some point in their lives. And a man's risk of prostate cancer is increased if he has a close relative, for example, father, or particularly brothers, or a member of the female side of the family who's had breast cancer, because that is linked to faults in the genes BRCA1 and BRCA2, which are also a risk factor for prostate cancer. I'd like to have the next click, please. So there you see it, 2.5. A man is 2.5 times more likely to get prostate cancer if his father or brother has been diagnosed with it, compared to a man with no family history. So I guess for men with a family history, or perhaps black men, or if one of the female members has had breast cancer, then it would be worthwhile knowing one's PSA. And certainly in my practice, I like patients to know their weight, their blood pressure, their cholesterol, and their glucose. And if they had a relative with prostate cancer, I like them to know their PSA level. And the next slide, please. So prostate cancer is now the most commonly diagnosed cancer in England. 49,000 men diagnosed with prostate cancer in England in 2018. That was the highest ever recorded. And of course, we have around 400,000 who are living with or after the diagnosis of prostate cancer. So this is quite a common disease. And certainly GPs will have a considerable number of men on their practice list who possibly harbor prostate cancer, but have also had prostate cancer. And the next slide, please. The thing is that we're actually quite good at treating prostate cancer, and 78% of people survive prostate cancer for 10 years or more. And in fact, certainly since I did that original PSA screening study, there have been many, many advances in the ability to diagnose prostate cancer and how we treat prostate cancer. And the next slide, please. So let's look at these tests for prostate cancer and whether we should screen all men or just test. And when it's time for you to be referred to hospital for further tests. And the next slide, please, David. So we're going to explain some of the tests that are used to recognize and assess prostate cancer. And some of these tests can be done in your GP practice. They're routine blood tests and examinations and relatively painless. The digital rectal examination and PSA test itself can't diagnose prostate cancer. It can raise suspicions that the man might have it, but you do need referral to hospital for further tests to reach the diagnosis. And that will include an MRI scan of the prostate, which is done at the hospital. And that gives beautiful pictures of the prostate. And one of the advances that's been made with MRI scanning, it means that we can actually take a biopsy of one special area of interest. We don't have to biopsy the whole gland like we did in the past before we had MRI scanning. But a biopsy is normally required to confirm whether you or do not have prostate cancer, because we need to see the cells to see whether they're malignant or not, and actually how malignant they are. And the next slide. So what about this digital rectal examination? And that's examining the prostate through the back passage with a finger. And normally you'll be asked to lie on a couch on your left side. And as long as you're happy about the procedure being performed, the doctor or specialist nurse put a gloved finger into the rectum. And this test is to feel and examine the prostate through the wall of the rectum to see what the prostate feels like. Is it large? Does it have hard areas within it? Is there a lump? Or is it just soft and generally enlarged? But any enlargement or hardness or a lump could be a possible sign of prostate cancer, and that would mandate a referral to hospital. But a rectal examination alone cannot diagnose prostate cancer. It can only raise suspicions. And then you'd need an MRI, and subsequently, if the MRI is positive, a biopsy. About 28% of men can avoid a biopsy by having an MRI, because the MRI can show that the prostate is actually quite normal. It's benign enlargement, not malignant enlargement. And the next slide, please. So what is this PSA, prostate-specific antigen? It's a protein made by the prostate, which is meant to stay within the prostate. It's actually a protease enzyme, which is there to liquefy the ejaculate semen. If there's something wrong with the prostate, the PSA, which should remain in the semen, not get into the blood, leaks into the blood. This happens commonly with benign enlargement of the prostate, or if the prostate was inflamed with prostatitis. Or it can even be raised if you've done vigorous exercise or been riding a bike. A small blood sample can be taken from the vein, and with that blood sample we can measure the prostate-specific antigen level. And we have a normal range of up to 3. And the next slide, please. So by measuring the PSA, we can use it to raise our suspicions that the man might have prostate cancer. And we can also use it to follow men up when they've been treated for prostate cancer. Because if you have your prostate removed, there shouldn't be any PSA in the blood. And if you've had radiation therapy, PSA level will be very, very low. But if the tumor starts to come back, then the PSA will once again rise. So we can use it to monitor at follow-up, and it will help us decide what further treatments are needed if the PSA starts to climb. And the next slide, please. So what does the PSA actually tell us? As I said, for a man aged 50 and above, a PSA above 3 nanogram per mil is considered raised. But we need to remember, if you have a PSA between 4 and 10, only 1 in 4 men will have prostate cancer. So 3 out of 4 will not. So an increase in PSA in itself is not a diagnosis of prostate cancer, because it will go up with benign disease, prostatitis, riding a bike, or ejaculating. So it can be raised for other reasons. If you have a PSA less than 4, your risk of prostate cancer is only 15%. If it's between 4 and 10, your risk is 25%. If your PSA is above 10, then the risk is 50%. And the young man who got me interested in this disease, his PSA was over 5,000. He was diagnosed very late, which started me on a mission to try and diagnose prostate cancer as early as possible. And the next slide, please. So what are the benefits of having a PSA test? Well, it could lead to the detection of cancer before symptoms develop. It may lead to the detection of cancer at an early stage when we can cure it, or when we can start treatment early and extend life. And repeat PSA tests provide very valuable information about follow-up and progress of the disease. And it does aid us in making a diagnosis of prostate cancer. But the test, like many tests that we do, has limitations. These potential limitations include the fact that, as I've said, that PSA is not diagnostic, and the level can increase due to a number of other factors. And the next, please. So this is the Prostate Cancer Risk Management Program. I've been on their advisory scientific committee for the last 15 or 20 years. And the idea is that we're supplying information to help GPs counsel patients about pros and cons of having the test, and provide information to GPs about what things might influence a high PSA. But remember, the NHS has stated clearly that a PSA test is available free to any well man over 50 who requests it. So it does give that man a chance to know his number. What is his PSA? And for people at risk, such as a strong family history, or Afro-Caribbeans, for example, it might well be very worthwhile knowing what their baseline PSA result is. And the next slide. So you can download this advice sheet from the internet, from the Prostate Cancer Risk Management Program site, and it tells you all about the PSA test, a lot about prostate cancer, and tells you about the pros and cons of having the test. Because as I said, when we first did that screening study, we did some harm because we caused some infections. And we were having at that stage to do multiple biopsies because we didn't have MRI scans available. And the next slide, please. There is a difference between screening. So, for example, that is testing all healthy men over 50 with a PSA test, or case finding, in which case we would simply do a PSA in men who were at risk, men who had symptoms of prostate disease, or men who wanted to know what their PSA level is. So for prostate cancer, testing in a targeted way appears to be better than testing the whole older population of men. And the next slide. So, as I've said, any man over 50 is entitled to a PSA test free on the NHS. And if you want to have one, you should speak to your GP. But in the UK, we don't screen all men over 50 with tests like DRE and PSA to look for prostate cancer. we test men at risk with symptoms or men concerned about problems. And for example, breast cancer screening for older women has been shown to help catch more cases of breast cancer earlier. So the case is made for doing mammograms, and the same is true of colon cancer screening. A large study by Cancer Research UK has found that screening older men for prostate cancer did not help find more cases of prostate cancer than just simply medical testing, the men I've discussed already. And the next slide, please. So if you go for an examination and have a rectal examination and have a blood test and the PSA is raised, then you will be referred to a specialist urologist to confirm or dispute the diagnosis. So the further test that will be done will be an MRI scan and a prostate biopsy. And the biopsy has been done in a different way now from when we first started doing it, because we had to take a biopsy through the rectum, which of course increased the risk of introducing infection into the prostate. Now it is done through the perineum, which is a much cleaner way to do it and much less likely to cause infection in the prostate. And the next slide, please. So just to summarize, prostate cancer is worryingly the most common cancer diagnosis made in men. And as we get older, the risk of prostate cancer increases, and most of the men who get diagnosed with prostate cancer are in their late 50s and middle 60s. If you think that you are at high risk of prostate cancer because of a familial history or because of your race, then you should speak to your GP and get his advice about the pros and cons of having a PSA test. The problem is that prostate cancer is a potentially progressive disease. So finding it early in stage 1 or stage 2 where we can cure it is very important, because we want to remove the tumor before the cancer spreads outside the prostate gland. The outlook for men with prostate cancer can be very good. And in fact, more men live with prostate cancer than die of it. And this is partly because these are older men and there are competing causes of death, such as heart disease or stroke. Prostate cancer often has no or few symptoms, particularly in the early stages, because about 75% of these prostate cancers occur in the peripheral, outside parts of the prostate, and they're not encroaching on the urethra in the middle, causing urinary symptoms. So it can be there really without any symptoms. We do have tests such as the rectal examination and the PSA test, which are the first step towards making a diagnosis of the disease. But to get a definitive diagnosis, then you will need referral to see a specialist.